We are going to talk about management of chronic hepatic encephalopathy. Is there a single most important tool for the diagnosis of hepatic encephalopathy? This is a question we should start by. No, but arterial ammonia levels can be strongly suggestive. An elevated blood ammonia level is the classical laboratory abnormality reported in patients with hepatic encephalopathy. This finding may aid in correctly diagnosing patients with cirrhosis who present with altered mental states. However, serial ammonia measurements are inferior to clinical assessment in gauging improvement or deterioration in a patient under therapy for hepatic encephalopathy, and checking the ammonia level in a patient with cirrhosis who does not have hepatic encephalopathy has no utility, and only arterial blood ammonia specimens must be assayed when checking the ammonia level. Classical electroencephalogram changes associated with hepatic encephalopathy are high amplitude, low frequency waves, and triphasic waves. Visual evoked response also demonstrate classic pattern associated with hepatic encephalopathy. However, these tests, both electroencephalogram and MRI and even triphasic CT, are not used in clinical condition. What are the differential diagnoses of hepatic encephalopathy? Distinguishing hepatic encephalopathy from other acute and chronic causes of altered mental status may be difficult in patients with cirrhosis, and a decision to perform additional neurological studies should be based on the severity of the patient's mental dysfunction, the presence of focal neurological findings, and the patient's responsiveness to an empiric trial with the accepted measures. These are the common differential diagnoses of the encephalopathy, including intracranial lesions such as subdural hematomas and the brain abscess, infections like meningitis and intracranial abscess, metabolic abnormalities, electrolyte disturbance, hypoglycemia, and uremia, hyperammonemia from other causes, and Dr. Sam will discuss later on, toxic encephalopathy and toxic from drugs such as sedatives, hypnotics, and antidepressants. How can hepatic encephalopathy be managed? The approach to the patient with hepatic encephalopathy depends upon the severity of the mental states as we mentioned. General management recommendations include: exclude non-hepatic cause of altered mental dysfunction, consider checking an arterial ammonia level in the initial assessment, precipitant of hepatic encephalopathy such as metabolic disturbances, GIT bleeding, infection, and constipation should be corrected. Also avoid medications that depress central nervous system function, especially benzodiazepines. Patients with severe agitation may receive haloperidol as a sedative, and patients with severe hepatic encephalopathy grade 3 to 4 should be managed in ICU, especially those at high risk for aspiration to be intubated. These are the common hypotheses of pathogens of hepatic encephalopathy, and the treatments are directed towards blocking all these measures: ammonia, GABA aminobutyric acid, amino acid imbalance with high level of aromatic amino acids and the low level of branched chain amino acids, and the false neurotransmitter theory. However, most current therapies are designed to treat hyperammonemia, that is the hallmark of most cases of hepatic encephalopathy. We have two lines: treatment to decrease intestinal ammonia production, and we first presented with the diet, and which was neglected in the past. But nowadays, diet containing vegetable protein appear to be better tolerated than diet rich in animal protein. This is because this protein contains high amount of dietary fiber, natural cathartic, and decreased amount of the aromatic amino acids, which are the precursors of the false neurotransmitters. Lactulose and lactitol are disaccharides that are not absorbed from the digestive tract. They are thought to improve the generation of ammonia by bacteria and render the ammonia inabsorbable by converting it to ammonium, and increase transit of bowel content through the gut. Doses should be 15 to 30 milli, are administered 3 times a day, and the result is aimed to be 3 to 5 soft stools per day. Lactulose may be also given by enema in the form of 300 milli lactulose plus 700 milli water as retention enema every 4 hours as needed, especially if encephalopathy is severe. This may relieve constipation, one of the causes of encephalopathy, and increase the bowel transit, but caution should be taken in consideration if diarrhea produced as a result of this dose of lactulose, and it may worsen the condition by producing hypovolemia and electrolyte disturbance, and should the dose be reduced. Antibiotics. The antibiotics neomycin and the metronidazole were previously used as a treatment for hepatic encephalopathy. Again, the rationale of this reuse was the fact that ammonia and other waste products are generated and converted by intestinal bacteria, and the killing of these bacteria would reduce the generation of these waste products. Neomycin was chosen because of its low intestinal absorption. 250 mg 2 to 4 times per day is usually considered a second-line therapy after initiation of lactulose. However, later studies showed that neomycin was indeed absorbed internally with resultant complications such as ototoxicity and nephrotoxicity, especially with long-term use. Metronidazole similarly was abandoned because prolonged use could cause peripheral neuropathy, nerve damage, and may experience GIT side effects. So we come to the rifaximin, which is an unabsorbable derivative of the rifampin, has been used in Europe for more than 20 years ago for GIT infections. In 2004, it was approved by the FDA in the United States for treatment of traveler's diarrhea. In 2005, it received orphan drug status as treatment of hepatic encephalopathy. In contrast to the neomycin, it is better tolerable. Dose 400 mg orally 3 times daily was effective as lactulose or lactulose, and also was effective as neomycin. In March 2010, it was approved by the FDA to reduce the recurrence of hepatic encephalopathy. The approval was based on phase 3 clinical trial conducted by Pass et al. He evaluated rifaximin ability to reduce the risk of recurrent hepatic encephalopathy. He examined 299 patients, received either rifaximin 550 mg PID or placebo. Each group also received lactulose. He found that breakthrough episodes of hepatic encephalopathy occurred in 22% of patients treated with rifaximin and 40% with the placebo. The side effects of the rifaximin include peripheral edema, nausea. However, there are questionnaires about long-term treatment can induce microbial resistance, and also Clostridium difficile occurs at high rate in those treated cases, and it may produce severe diarrhea, which may worsen the condition. Therefore, due to widespread experience, it is only used as a second-line treatment if lactulose is not effective or poorly tolerated. When added to lactulose, the combination of the two may be more effective than each component separately. Rifaximin is more expensive. البوكس rifaximin 505 ملغ 60 حبايه بيعملوا حوالي $1500 كده very much expensive than lactulose, but the cost may be offset by reduced hospital admissions for encephalopathy. Treatment to increase ammonia clearance, L-ornithine and L-aspartate, which are known about, and zinc administration has potential of improving hyperammonemia by increasing the activity of ornithine transcarbamylase, which results in increase in the ureogenesis and the loss of the ammonia ions. Zinc sulfate or acetate 600 mg orally daily is quite effective, and also L-carnitine, whether it improves the blood ammonia levels or works centrally by decreasing brain ammonia uptake, remains unclear. The recent literature does not include any treatment regarding the benzodiazepine and the benzodiazepine antagonists that were used, such as the flumazenil and also the branched-chain amino acids. They found that disorder of the astrocyte function, which result from the neurotoxic substances such as ammonia and the manganese, are the most common hallmark of the pathogenesis of the hepatic encephalopathy. And the genes coding for the peripheral type benzodiazepine receptor is upregulated in cirrhosis. ده باتر وورث عملها سنة 2003، بس احنا كان عندنا رسالة ماجستير سنة 91 كنا عاملين trace elements manganese وامونيا وكابر وزنك, and it was very close to this idea. في شوية اشتغلوا على experimental model and they found that neurotoxins like ammonia and manganese increase the production of the peripheral type benzodiazepine receptor in astrocytes, which in turn stimulate the conversion of the cholesterol to pregnenolone to neurosteroids. These neurosteroids are then released from the astrocytes. They are capable of binding to the receptor within the GABA receptor complex and they can increase inhibitory neurotransmission. بوشا اس et al. 2006 examined autopsied brain tissue of patient died in hepatic encephalopathy showed elevated levels of the allopregnanolone, the neuroactive metabolite of the pregnanolone. On the other hand, brain levels of the benzodiazepine receptor ligands were not significantly elevated. What is the prognosis of the hepatic encephalopathy? The prognosis for a patient with encephalopathy depends on the initial causes and in general the length of the time it takes to reverse, stop or inhibit those causes. Consequently, the prognosis varies from patient to patient and range from complete recovery to a poor prognosis that often leads to permanent brain damage or